right, guys. So we can get started. My name is Janani Ahmed. I'm one of the second-year EMIMs. For those of you who don't know me, I'm going to be talking about pre-hospital and disaster medicine today. Thanks to Dr. Dukas, Dr. McMahon, and Dr. Silver for their help with this presentation. Okay. All right. So at 8:09 a.m. on March 20th, 1995, the first emergency call was made regarding a mass casualty event that had taken place at multiple subway stations. The total number of victims was unknown. It would unfold over the next several hours that a domestic terror group had released a nerve gas agent called Sarin, causing a constellation of life-threatening symptoms across the city. In total, 131 ambulances and around 1,300 emergency personnel were dispatched to respond to the event. At this time, around 8 a.m., Tokyo area hospitals were notified that a gas explosion had taken place and to prepare for burns and carbon monoxide poisoning. So today I'll be discussing the cholinergic toxidrome through the lens of the Sarin Tokyo subway attack. So briefly, we'll cover mechanisms of cholinergic poisoning, supportive care, and antidotes, and discuss preparedness at the hospital level for mass casualty events requiring decontamination. So let's briefly review the mechanism of cholinergic toxicity. It's caused basically by substances that stimulate, enhance, or mimic the neurotransmitter acetylcholine, the primary neurotransmitter of the parasympathetic nervous system. This can occur through inhibition of acetylcholinesterase, whose role is to break down acetylcholine, or through direct stimulation of these receptors. The effects can be divided into impacts on the nicotinic and muscarinic receptors, with the majority of dangerous results of parasympathetic overstimulation resulting from muscarinic effects. Nicotinic receptors are present largely in skeletal muscles, if you recall, but muscarinic receptors are kind of all over the place. They influence the exocrine glands as well as inherent activity of smooth muscle in the cardiac conduction system. So one way to sort of think about parasympathetic overdrive is excessive vagal tone. This can help you kind of quickly think of what those effects might be, which is increased GI effects, bronchoconstriction, increased respiratory secretions, and kind of a very slowed heart rate. And so I'm sure you're all familiar with the mnemonic sludge for cholinergic toxicity. And so you can see here salivation, lacrimation, urination, defecation, GI cramping, emesis are kind of those things that may clue you in that you're dealing with something that someone who may be suffering from cholinergic poisoning. So these features are certainly present in something like a sarin poisoning, but it's also important to recall that they can happen in classically described organophosphate poisoning from pesticides seen in farm workers. This is also has the potential to happen on a large scale. So we'll discuss antidotes in a little bit, but central to care of these patients is also supportive. The more serious effects of cholinergic poisoning can be recalled by this mnemonic, killer bees. So that includes bronchorrhea or significant respiratory secretions, bradycardia, and bronchospasm. Respiratory failure is the usual cause of fatality in these cases, so it's important to kind of keep that in mind and initiate aggressive respiratory support early on. Between 8:40 a.m. and 9:40 a.m. on March 20th, 1995, 500 patients arrived at St. Luke's Hospital in Tokyo. At the site of the attack, responders were not wearing PPE. As a result, about 10% of the 1,364 fire department personnel who responded to the incident experienced secondary exposure while transporting victims to emergency facilities. 23% of St. Luke's staff reported signs and symptoms of secondary exposure. So I'd like to illustrate two major considerations at this stage in a mass casualty event involving a nerve agent. One, the worried well can make up a large portion of those seeking evaluation, and the truly sick must be quickly identified. And two, every hospital must have a plan for decontamination of casualties, as the risk of secondary exposure is very high. Ultimately, in Tokyo that day, 278 hospitals and clinics saw 5,510 patients. It was determined that of those patients seen in relation to this event, only about 17 were critical and 37 were severely ill. So as you can imagine, finding those 50 or so patients that were dying in kind of this massive influx of patients was likely a significant challenge. So it's natural to think that in the event of mass casualty, communication will flow mainly from the field to hospital via EMS and other community sources. However, available studies actually indicate that many chemically exposed patients arrive unannounced at the closest hospitals after being transported by themselves or by bystanders. So this is true in routine emergencies as well and disasters. The important point being that these patients weren't decontaminated at all and just kind of walked into hospitals all over the city. So during large-scale events, many patients can present to emergency departments anxious. This anxiety, as you all know, can have physiologic effects. People have increased heart rates. They have this kind of stress response just due to cortisol, epinephrine. And it's important that when we're dealing with a chemical or biologic agent, we're not contaminating people who aren't already sick. One review suggests that geographically triaging patients, that is looking at patients in relation to where they were when the event occurred, is a quick way to sort of make sure that we're not grouping together all these patients with potentially similar symptoms, and we're not infecting those who don't need to necessarily be seen right away. And then once an agent has actually been identified, decontamination processes can kind of be amended to streamline care more effectively. Right. Hospitals, as I mentioned, may have to deal with contaminated casualties before they've had time to don personal protective equipment or set up contamination showers. And so planning for expedient decontamination can include just having a setup in place already, having fire hoses, spray nozzles hooked up to a high capacity, low pressure, warm water supply. This way, it's kind of a temporizing measure to make sure contaminated individuals can be sprayed from a distance, but don't have to, expose hospital staff during that process. And also considering the weather that we might have in this part of the world, that we're not setting patients up for some hypothermia. Just things to kind of think about in preparation for an event like this that could happen. And since it's patients rather than the emergency medical services system that often determine where a patient goes, all hospitals must have some capacity to deal with contaminated casualties. All right, so per CDC guidelines, first responders should use NIOSH certified chemical, biologic, radiologic, nuclear, self-contained breathing apparatuses. So that's what this is. I think it would have been a more dramatic picture a couple of years ago, but I think this is just Tuesday in the pod. So we're used to this now, unfortunately. So following basic PPE practices, such as gowns, gloves, masks, face shield, should just be continued if contaminants are at all, on your radar, something that could be happening. But for nerve agents specifically, self-contained breathing apparatuses are kind of the standard PPE that should be used. All right, so this is actually a visual layout of the protocol at Kings County. So in a mass casualty event involving a chemical or biologic agent, patients will initially be taken to this decon visual triage table, where they will be inspected by nurses and other assigned members of the triage team, and will be registered into the EMR and given two identically numbered tags, one for for themselves and one for the belongings. At that time, patients who are deemed unstable will basically be moved to CCT room 5. And at that time, decontamination and patient care should occur simultaneously. Patients who are more stable will follow paths for decontamination here. And they'll go basically, the location of decon area is in the S building ambulance bay. And that basically includes the multi-person showers, which I didn't know were there, in the back of the S building, and to be accessed via the entrance on Winthrop Avenue. And during this process, if a decontamination protocol is sort of activated, hospital police should be present, responsible for directing patients who arrive to the decontamination area. So as you can see, there are some processes in place, but even if you look kind of at the different paths that patients may take, if we think about these could be potentially contaminated patients, these could be people who have the potential to get very sick very quickly. There are some areas we can sort of improve in terms of how we triage and move around patients if there were to be a mass casualty event. But it's also important to think about the setup of your emergency department and where where we might want to keep these patients to make sure that they get expedient care, but also so that we're not unnecessarily exposing other people in the department. All right. So let's move back to Tokyo. At 9:30 a.m., St. Luke's Hospital receives a call from a physician who had treated sarin victims in the past in a recent bioterror attack. The suspected agent at this time in Tokyo, however, was acetonitrile. The hospital continued to triage and provide supportive care to victims. Supportive care was critical, particularly since the toxin was still unknown to them. So as we talked about, respiratory supportive care is essential to the early management of severe cases of cholinesterase poisoning. It's most common cause of fatality in these cases, which is really a result of a combination of bronchoconstriction, bronchorrhea, central respiratory depression, and weakness and paralysis of the respiratory muscles. So severely affected patients may ultimately require intubation, and your choice of induction medication is actually quite important. So in rapid sequence intubation in these patients, if you're suspecting cholinesterase poisoning, you should avoid succinylcholine. This is because, as you might recall, succinylcholine is metabolized by acetylcholinesterase, which is inhibited in organophosphate poisoning. So this could lead to basically an exaggerated and prolonged neuromuscular blockade in these patients, which you want to avoid. Rocuronium can be used as your agent, but it may be less effective at standard doses due to competitive inhibition at the neuromuscular junction. So you'll likely need to plan to use increased doses in these cases. So around 10 a.m., Tokyo hospitals learned that the most likely toxin was sarin gas. They began to take steps to administer antidote. The manufacturer of the antidote saw media reports with the new information and rushed emergency supplies into the city. Stockpiles from rural hospitals were called in, and there were kind of all these different methods to get them into the city because this is something that they were not quite prepared for. So the two kind of main antidotes we'll talk about are atropine and pralidoxime, kind of the mainstays of antidote treatment in cholinesterase poisoning. So atropine is a competitive inhibitor of acetylcholine at the muscarinic receptors on smooth muscle, cardiac muscle, secretory gland cells, and in peripheral autonomic ganglia and the central nervous system. Pralidoxime works a little bit differently. It's a cholinesterase reactivator. So in cholinergic poisoning, the mechanism of deactivation of cholinesterase is binding of organophosphates to a particular site of acetylcholinesterase. So that results in reversible inactivation of the enzyme. And so this kind of breaks that down. All right, so EMS might actually be equipped in some places with what's called a duodose auto-injector. So this kind of device provides a single intramuscular dose of atropine and pralidoxime, and it delivers 2.1 milligrams of atropine and 600 milligrams of pralidoxime. All right. This is just an excerpt from the New York City EMS protocol that lay out treatment if suspected cholinergic poisoning is found in the field. So the goal of treatment is ultimately drying of secretions and resolution of other symptoms that we discuss in terms of that bradycardia, the drops in blood pressure, things that are kind of more critical. And so patients are classified as red, yellow, or green according to the severity of their symptoms. And patients who are green are asymptomatic and do not require treatment. Patients in the yellow or red classification can be administered duodose, followed by repeat atropine dosing of 2 milligrams at specific intervals, depending on the severity of their symptoms. And so this is all pre-hospital. This is all maybe not necessarily what we're going to work, but it's good to be aware of what can be done and what could have been done in the field when you sort of get your patients, because it's going to affect the next steps that you take. So in terms of atropine initiation in the hospital, when you typically initiate treatment, you're going to want to start at about 1 to 3 milligrams of atropine as a bolus, depending on the severity. But as I mentioned, you may need to be starting higher than this if you know the patient has already received atropine in the field and is still continuing to have severe symptoms. 5 minutes after giving your initial dose, you're going to check the clinical status of your patient, namely check their pulse, blood pressure, and if they have continued severe respiratory secretions. And if no improvement has taken place, then you're going to want to double the original dose of that atropine. And you'll basically continue this process until you achieve, sorry, that's a little until you achieve a change in their clinical status. Once you see some improvement, you can continue giving atropine in those every 5 minutes in those boluses at that present dose that gave you that response. And then once you kind of reach that high dose, then you're going to continue it until a specific endpoint is achieved that we'll discuss. And so these are kind of the specific endpoints we look for to say that we can back off on those boluses of atropine. And so you're going to look for a resolution of bradycardia, or clearing of respiratory secretions, just general improvement in the respiratory status. And once a patient is a little bit more stable, you can start an atropine infusion. And typically the dosing of that is going to be 10 to 20% of the total dose that you needed to stabilize that patient per hour. All right, and moving on to pralidoxime, it's administered via infusion. And so initially, you're going to start with 2 grams of pralidoxime over 15 minutes. It's important to give it quickly if you're suspecting cholinergic poisoning, as it's only effective if irreversible binding of organophosphate has not already occurred. The initial dose, as mentioned, is 2 grams, and you want to give this pretty at that kind of stage of over 15 minutes. If you give it any quicker than that, you can start to cause a neuromuscular blockade and risk of laryngospasm. And so kind of stick to that time period. And this should be followed by pralidoxime infusion at about 500 milligrams an hour. Pediatric dosing is a little bit different. You start usually with the initial dose of 25 to 50 mg per kg, followed by an infusion of 10 to 20 mg per kg per hour. Typically, infusions can be discontinued after about 24 hours if the patient is well. Patient will require some close observation. If they sort of have recurrence of any symptoms, you can restart the infusion. All right. So just wrapping up in Tokyo, the death toll on the day of the attack was 8 individuals, with 4 more patients passing subsequently in the coming days from the effects of poisoning. In the year since the attack, 2 more deaths have been attributed to long-lasting effects of poisoning. Interesting thing about St. Luke's Hospital, it had actually been recently outfitted as a field hospital designated to function in the event of a major disaster. And so this kind of fortunate coincidence has been credited with the prevention of further mortality due to their ability to triage and treat a large number of patients very quickly. Just to wrap up, just a couple of takeaways. Rapid identification of cholinergic toxicity is key. Your most important tool is your history and examination. There aren't really any lab tests or anything that can quickly point us in one direction or another with cholinergic toxicity. And so you really have to look at your patient and see what's going on and see if you can identify that this might be it. And then second, aggressive decontamination is essential to prevent worsening of symptoms and avoid secondary decontamination. Third, respiratory support is critical, along with early administration of antidotes. And lastly, we didn't really discuss, but should be on your mind if toxicity or poison control consultation is recommended in the care of these patients. This is, while these are all kind of guidelines that are out there, this is not something that any of us probably see very often. And so kind of checking in with if there's anything else that we can offer these patients should be one of the first things that somebody does on your team. All right, and that's all I have.